Good afternoon, everyone, and welcome to this From Insight to Action, a training series for Maine's service providers, sponsored by the Adept Institute of Maine and the BIAA Maine Chapter. Today's topic, brain injury in the community, with Dr. Douglas Gomez. The BIAA Maine Chapter gratefully acknowledges partial support for this training series for the administration from Community Limited, the U.S. Department of Health and Human Services, and the Maine Department of Health and Human Services. To ask a question, we please request that you type it in the Q&A box of your control panel, and at the conclusion of the presentation, we will read as many of these possible to our presenter. Our presenter today is Dr. Douglas Gomez, Assistant Research Professor working at the Center on Brain Injury Research and Training, CBERT. His interests primarily focused on methods of qualitative analysis, particularly in the service of benefiting traditionally underserved populations. At CBERT, Dr. Gomez currently works on studies with the goal of reaching a better understanding about how parents, educators, coaches, and medical professionals can help facilitate improved services for individuals who have sustained a TBI. He is also a licensed psychologist with experience working clinically in state hospitals and correctional settings, which instilled in him a firm belief in the importance of research informing practice and practice informing care. Welcome, Dr. Gomez.
All right. Thank you very much for having me. So today I will, despite that wonderful introduction, I'm going to talk a little bit about kind of some of my background, certainly related to brain injury, and also just sort of how my experience has impacted that. And then I'll get into kind of some bullet points and start the presentation. One other thing that I'll just note is that I have, fortunately, this is pretty great. I have a couple opportunities to meet with you all. So today I'm going to be talking a lot about sort of brain injury and what it looks like and how it impacts us in some ways, certainly that we can provide accommodations. And then I'll also be talking quite a bit the next opportunity about psychological considerations and de-escalation, which are some of my favorite topics to talk about. So yeah, my two kind of primary roles, I'm a psychologist out here in Oregon. I work at an inpatient substance use facility called Serenity Lane. I've worked kind of all over. Basically, the thing to know about me is that I really appreciate working in kind of spaces where you'll notice high acuity and severe persistent mental health concerns, mainly because I know everyone doesn't like to work in those spots. So if you find out that you do like to work in a place like that, and I'll just say this for everyone in basically every presentation I give, like if you're one of these people who has a heart for this kind of work, please, do it, take advantage of it, because everyone doesn't. The other thing that allows me to do this kind of training is I'm an assistant professor at the University of Oregon. The main part about that is just that it allows me to both do research and practice. When it comes to folks with brain injury, similar to just about every other research capacity that we have now, there's a huge gap when it's looking at how soon we know about something and do research on it, and then how soon we're able to put it into practice. And so I'm really fortunate I'm able to kind of sit at the nexus of those two things. All right, today I'm going to be talking about just a few primary bullet points. So again, if you've ever seen me present, it's really, really important for me, even if you're somebody who feels like you have a really good understanding of brain injury versus someone who maybe doesn't see it as much in your work or in the community, it's good to know what it is, how we talk about it, who is at greatest risk, what communities are at greatest risk, and then talk about screening and then what it actually looks like to work with folks with a history of brain injury. I kind of talk about and think about my presentations as like, I start off a little bit with doom and gloom. There's kind of no other way to do it when it comes to brain injury, but fortunately I always finish with like, here are some accommodations, here are the things that we can do that maybe we're sort of even underestimating the importance of. All right, so what's a brain injury? So I'll always read this definition. So brain injury means damage to the brain from an internal or external source. It results in impairment in critical functions, and it is of sufficient severity to produce some form of disability. All of these functions can be limited, these lists that I have here below. But I kind of just want to note that the way that I will talk about brain injury as often as I can is I'll actually refer to it specifically using that language. So I'll say brain injury. Some spaces, I've worked in Oregon for a long time. I feel really lucky that in Oregon, when we're referring to brain injury, we can just say brain injury. We don't need to say TBI. But there have been some spaces that I've worked, for instance, where it's really important that you just say traumatic brain injury. The problem with that is related to this next slide. So there is a significant portion of brain injuries that are considered traumatic brain injury. Some of the ways that you might sustain them would be things like motor vehicle crashes, sporting accidents. The primary way, the way that I see the most often, is falls, and falls at greater than 50%. So it's not a coincidence that, like, despite the fact I'm really interested in brain injury, I'm part of our Oregon Falls Coalition group. Like, those two things are kind of inexplicably tied. And at the same time, traumatic brain injury is this very specific group, but it leaves out some of these other groups. There are actually states where when I'm talking about brain injury, I am only allowed to say TBI. I'm not allowed to refer to some of these other forms of brain injury, which is pretty problematic in my mind based on the prevalence of these other mechanisms for injury. So you've got things like, right off the bat, disease, COVID-19. We do not have a full understanding of how COVID impacts, how long COVID impacts the brain, how COVID-19 in general impacts the brain, and what would be considered brain injury. Obviously, things like Alzheimer's, MS, Parkinson's, all of which are considered forms of brain injury, cause forms of brain injury, but are left out if we're just talking about traumatic brain injury. Lack of oxygen, so anoxic or hypoxic brain injuries. The primary way that I see things like that are actually through, I work in an inpatient substance use facility, so fentanyl overdose. Opioid overdose actually leads to what we would consider like a lack of oxygen, anoxic or hypoxic brain injury. And again, if we're just talking about just looking at TBIs, traumatic brain injury, those folks get left out. Stroke works in a really similar way. And then as I mentioned below, alcoholic drugs can also be toxic to the brain. So it's not just that, you have an opioid use disorder and you had an overdose and then that led to a lack of oxygen. Some people have talked about things like methamphetamines. Some people have talked about things like benzodiazepines having negative relationships with the brain. Some people talk about that as brain injuries. And again, if we're just talking about TBIs, that stuff gets left out. So a really important thing, I think, for providers to be thinking about is just that brain injury should encompass all of these types of injuries. The other note that I always love to point out on this particular slide is just that you may notice there is an 18% here, which is like other reasons, other sort of physical injuries. The primary ways that the CDC has broken this up historically is that if it's somebody who like showed up to an ED, for instance, and didn't know how they sustained their injury, those folks would be categorized in this other group. And then the other one that I like to bring up, because I think it's very relevant, particularly these days, is that categorized within this other reasons category is actually interactions with law enforcement. So if you had a negative interaction with law enforcement that resulted in a brain injury, there are enough of those to actually meet criteria so that it's been documented by the CDC and is included in this percentage. It's just included in these other reasons. So if you want to break that down, you're welcome to kind of take a look at that. All right. The next piece is sort of what I referenced when I was first talking about brain injury. And that's just these brain injury signs and symptoms. So what's important about brain injury signs and symptoms is that normally when I talk about brain injury, people go, okay, I'm aware of the cognitive and I'm aware of the physical. So some of these really typical kind of cognitive signs and symptoms are issues with speech language, issues with attention, issues with learning and memory. Some of the kind of typical physical signs and symptoms are this slowed movement, coordination issues, headaches, balance problems, this kind of stuff. People mostly can guess at that. Even if you don't have a great understanding of brain injury, you could kind of guess at some of those symptoms. What gets left behind really often, and when I say left behind, I mean, for mental health providers get misdiagnosed all the time, misattributed, are some of these emotional and behavioral signs and symptoms. So depression, anxiety, irritability, and mood swings all have very significant relationships with brain injury. I'm going to go into like a lot of detail on exactly what some of those relationships are and how they manifest, but suffice it to say that they have a strong relationship. It's documented through research. And also, if a person had a history, for instance, of depression or anxiety or mood swings, a brain injury not only can cause some of those symptoms, it can actually exacerbate those symptoms very significantly as well. The other one that we see quite a bit is this behavioral signs and symptoms. And so what's hard about behavioral signs and symptoms is if you're dealing with somebody who's aggressive, impulsive, and has anger management challenges, social skills challenges, it's pretty easy to make assumptions about that person and think, well, that's just not a nice person. That's just not somebody I want to spend time with. And what's hard is a lot of times when I'm doing trainings for folks, I'm going into spaces like the Department of Corrections where they're saying, yeah, all these people who I work with are so rough, so terrible to work with. And then all of a sudden I'll say, well, what would it mean to you to say that some of these stats, like probably the most conservative would be like 50% of the folks that you work with in corrections have a history of brain injury. Does that impact the way that you view aggression, impulsivity, and anger management issues, knowing that this is not just a person who's like unpleasant to be around? It's pretty likely that this is somebody with a history of brain injury as well. So it breeds a different form of empathy to understand these emotional and these behavioral signs and symptoms of brain injury. All right. Also, brain injury, I mentioned cognitive impairments. I kind of want to go into those with a little bit more detail. What it looks like in practice, a lot of times for folks, is decreased attention and concentration, memory difficulties, impaired judgment, and reduced ability to follow instructions. Why I bring those specific cognitive impairments up is that if you work in a certain space and you see a certain type of person or typology of person regularly, you're going to make assumptions about what causes their symptoms. And I'll give you an example. So if I'm working as a psychologist out in private practice and someone comes to me and they say, Doug, I've had issues with decreased attention, problems with my memory. My friends say I keep making the wrong decisions or I make these really impulsive decisions all the time. If I'm just doing, for instance, like ADHD assessments, my first thought is going to be, okay, great. Let's figure out if this is ADHD. And so we'll have whole conversations about that. If I'm working in the facility that I work in now and I'm working in a rehab and I'm in the hospital unit and someone says, yeah, I've been having horrible decreased attention, memory difficulties, impaired judgment, impulsivity, my first thought in that space is going to be, okay, are we talking about a substance use disorder? How much are you drinking? How much methamphetamine are you using? Have you had a recent overdose? Like, I'm going to be thinking about what are some of the substance use related impairments that a person might be dealing with. What I would posit to you and what I really, really, really hope that people will take from this is not that you'll like memorize every single slide that I have and know every single sign and symptom related to brain injury, but more that you'll be thinking about brain injury. It'll be closer to the front of your mind. So that when someone comes in and they're reporting a certain group of symptoms that maybe looks like these ones here on the left, or some of these issues with social interaction, problem solving, skill acquisition, that your first thought isn't, oh, this person's just like socially awkward, or they have social anxiety, or they're socially anxious, or they have ADHD, or they have a substance use disorder. I'll just add another one to the list. Like maybe we should also consider, does this person have a history of a problem with brain injury? Okay. Other things, just to sort of hopefully not belabor the point, but just give some more examples that brain injury can look like, is it absolutely can look like grandiose planning, failure to make a plan or follow a plan at all, failure to initiate activity, difficulty in completing tasks. If you're working in a facility and your first thought is, okay, I've got somebody with kind of some grandiose planning and they're struggling to make a plan, and maybe they're reporting, all of these different things. I've had lots of folks with brain injury who will have some confusion about like what's their role in an agency, and so they're telling you, yeah, I'm the CEO of this agency. You might be thinking, if you're a mental health provider, am I talking to somebody who's in a manic episode? Am I talking to somebody who's maybe a little bit hypomanic and this grandiosity is coming from a different place? So, yeah, just again, not to belabor the point, but I think it's really, really important to consider that just because you look at a list of symptoms doesn't necessarily mean that you are, you know, not going to be impacted by the work that you're doing directly. You're going to be thinking about the things that you see most often. My hope is to also implant upon that. Let's talk about brain injury as well if we're seeing these types of symptoms. All right. I guess I put in a couple of opportunities just for questions and discussion, but it sounds like we're going to do a lot of that in the end. So maybe I'll skip through this part.
Dr. Gomez, if you want to answer them now, we've got 3. It's up to you if you want to wait or answer now.
I would love to answer questions now if there are questions. Yeah,
Sure.
absolutely.
I have 3 that have already came into Q&A. So the first one was, can you elaborate on a negative interaction with law enforcement as regarding a TBI, or did you mean by getting beaten by a cop?
Literally, the latter example is mostly what it is. Negative interactions with law enforcement, what I'm talking about it is like, you have somebody who's engaging in impulsive behavior. They have an interaction with law enforcement and they're not thinking through the consequences that they're an unarmed person and law enforcement are holding weapons. And unfortunately, those folks end up getting hit, thrown to the ground. We have horrible, horrible examples of folks who have been, lost oxygen as a result of interactions with law enforcement. So all of those things absolutely lead to brain injury. And so when I'm saying negative interactions, I'm not intending for it to be coded. I literally mean just like, yeah, you can get beat up, you can lose access to oxygen, all those sorts of things.
Great, thank you. We have 2 more. The next question was, does HPA axis disturbance through adrenal insufficiency or steroid dependency or injury secondary to medical issues such as lack of oxygen, frequent falls qualify as a TBI?
All right, I'm going to need to read that question to make sure that I fully understand it. Let me see here. I'm looking through chat just to see if it's in chat.
It's going to be in questions and answers. So it sounds like their question, they're asking if there's adrenal insufficiency or steroid dependency secondary to lack of oxygen. Would that?
Oh, I see what you're saying. Yeah.
Yes.
So hopefully I'm understanding the question correctly, and definitely correct me if I'm not. But essentially, if you've got anything that's causing a lack of oxygen to the brain, anoxic or hypoxic, even if it's for a short period of time, so things like the big example that we see quite a bit that I'm going to talk about in a second is like IPV, strangulation as a result of interpersonal violence. They absolutely would meet criteria for a brain injury. So essentially, if there are any examples of again, anoxic would be no oxygen to the brain, hypoxic would be little bits of oxygen to the brain. Either of those issues absolutely would be considered brain injury. The other thing that's really hard and that I brought up earlier is that like certain substances impact the brain in really meaningful ways. So I brought up methamphetamine a couple of times. Some people would call methamphetamine-induced psychosis or a psychosis as a result of substance a brain injury as well. And that's where we get into these like really challenging definitions. So specific things like use of steroids in certain ways, like all of those are going to be definitionally the type of thing you could argue, like does it result in lack of oxygen in the brain? Yes, then likely I would consider that a brain injury. Other folks might consider it something different.
Great. So another example question came in. If someone has an intellectual disability and a seizure disorder, and they've been using alcohol quite heavily for the past year, and this has led to an increase in challenges, as you've noted, is it possible that the seizures can be affected by alcohol, or is it possible he could have a brain injury from this?
So both could be true. A pretty classic example, unfortunately, of what happens if a person is drinking alcohol heavily and then stops, they can go into what's called DTs or delirium tremens. They can also have seizures. They're at high risk of seizures. Not using alcohol at high rates and using benzodiazepines at high rates and then stopping can absolutely lead to seizures. Seizures have a really, really strong correlation with brain injury, and in some places are actually considered brain injury. So again, that's where we get into this kind of definitional difficulty. What I would say though is if you have a person with a substance use disorder, in this case alcohol, and they have a history of seizures, I would be very surprised if at some point they weren't diagnosed or didn't have symptoms really consistent with a brain injury. The other thing to remember about that is just that both of those things, seizure disorders and alcohol use disorders, are strongly correlated with falls. And falls is the primary way that a person would actually sustain a brain injury, according to CDC data.
Great, thank you. And then before I read the next two questions, are you going to be discussing in the future slides a few minutes about more about drug overdoses and concussions?
I'm going to be talking about, let's see, drug overdoses and concussions. Probably not too much more after this. So I'm happy to answer a question on that if there
Okay,
is one.
so we have two questions in off that. Can you tell us more about drug overdoses when there is a lack of oxygen?
Yeah, so opioid overdoses. Essentially, what happens is like physiologically, when you're going through that overdose process, you are not receiving enough oxygen to your brain in that moment. So what's hard about that is a lot of times people will be working clinically. They'll see somebody and they'll say, "Oh, okay, I've worked with this person before, and the only thing that's changed is in this last week they actually sustained an overdose." And so they'll notice almost immediately, hey, this doesn't seem like the same person I was working with a week ago. And it may be cognitive deficits, it may be issues with working memory. There are a lot of different factors that can change. They can even be like personality related changes. And so I think what ends up happening sometimes is people don't make the connection that when someone overdoses, even if you have a Narcan available and you're able to have them survive the overdose, it doesn't mean that they've not sustained a significant brain injury.
Dr.
Great, thank
Gomez,
you.
this is Patty here. I just wanted to maybe kind of encapsulate some of those. We do have some presentations that are specifically on overdose and brain injury for Maine that I can reference people to. I'll drop my email in the chat. And there's some questions about evaluations for brain injury. I'm sure you can talk about the professional end, but also here in Maine, we do have access to the OBIS online brain injury screening and support system. So again, I'll drop my email in the chat. So if people want more information about that, they can reach out to me. That way we can kind of answer some of those for
Awesome.
you.
That is super helpful, and I will go into brain injury screening. So that's exciting that I get to talk about it in the context of having access to OBIS, because Oregon we don't have access yet. We're close, so I will bring that up. Thank you, Patty, for bringing that up. All right, so I'll go forward, and then I'm trying to pay attention to questions though, so I'm happy to answer things. Stop me at any point, any of y'all, if I'm going too fast. All right. So the other thing to be thinking about that I've sort of referenced in a couple of different capacities is who are communities who are at increased risk of brain injury. So I sort of put together a little bit of here's a bunch of these groups put together, more prevalent within older adult populations. Hopefully you can intuit some of that. A large percentage of those are related to increased fall risk, individuals who are at risk of being unhoused, veterans. I do a ton of work with veterans. I maybe have a slide or two on veterans, but I didn't include all of them here because it's a group I'm really passionate about, and they are not receiving the brain injury services that they need and deserve right now across the country. Anyone with a mental or behavioral health condition, people with history of diagnosis, which I will get into. It's like the primary starting topic of my next presentation. Victims of IPV or DV absolutely are at high risk, and then those involved in the justice system. All right, so just starting off with older adults, some kind of clear things that, again, sometimes we can intuit these things, but we don't always think about them. Those folks are more likely to be taking medication, which do increase fall risk. So things like anticoagulants, things like benzodiazepines, which I referenced earlier. There is absolutely, unfortunately, a poorer long-term prognosis post-injury, and that's related to age. And it's maybe something you can intuit, but it's a pretty clear sign as we get older, our brains become less neuroplastic. It's harder for us to heal in the same way, and therefore prognosis becomes poorer. Adults age 75 and older, unfortunately, account for the highest rates of hospitalization and death as a result of just traumatic brain injury. So that number gets higher when we're talking about other forms of brain injury, including things like seizure. And then interestingly, 1 in 8 older adults are estimated to have experienced a TBI at some point in their life. And there's more data too related to what percentage of those folks also are having symptoms as a result of a TBI. I do see one question here about sharing slides. Like, please, by all means, like the one thing that I say whenever I present, I want people to have access to this information. Like, I want people to, like, if you work in an agency and you want to just take a slide and say, hey, I want to, talk about this slide that I heard about in this presentation, like, please do that. And if you have a question about something, send me an email. I'm more than happy to respond. Like, this stuff to me is not intended to be proprietary. This is stuff that we want out in the community. So like, by all means, any access to anything, just let me know. Other things about older adults and brain injury, I sort of referenced falls being the leading cause. More than 1 out of 4 Americans age 65 plus does fall each year. This is all from our Falls Prevention Coalition group that I mentioned. And the majority of falls happen in the home, 30% in a public setting and 10% in a healthcare setting. So just again, thinking about like where people are at risk, I think with brain injury, people make assumptions that you need to be engaged in like really risky behaviors, activities. Maybe you're like out on ATVs all the time, or you ride a motorcycle, and those are the things that put you at greatest risk of a brain injury. The reality is like falls is the primary mechanism, and the place that it happens most often is in the home. So you want to be aware of it. It's going to be a part of our lives in some form or fashion. So we want to be thinking about it a lot. I mentioned service members and vets. I said I only included 1 or 2 slides. I hope it's just 1 or 2 for your sake, but I'll go through them quick. TBI is considered the signature wound of Iraq and Afghanistan. So the signature wound is the way that it's documented in data. When you see certain percentages, I've seen numbers at like 10% of every veteran or person who's seen combat. I've seen it all the way up to 40 and 50%. It's considered a significant wound for Vietnam vets. The most important thing that I always talk about with this, though, is that despite the fact, I'm going to check to make sure I didn't include the slide. Yeah, I didn't. So despite the fact that people make the assumption that the way that you're going to sustain a brain injury, most likely, if you're a veteran, is like blast injuries or like a puncture wound to the head, these types of things. This data that I presented earlier, this CDC data I presented earlier related to TBI, it holds up even when we're talking about someone who is actively in the service. So falls is still the #1 way that you're likely to sustain a brain injury if you're in the military, which is really, I think, a really powerful, important thing to recognize, that this data is held up across whether or not you're somebody who's, engaging in combat training regularly, or you're somebody, living in the US and, you're not getting out in the same way. You're still at a pretty high risk when it comes to falls. Other things to note about veterans and brain injury is just, and again, like, you're welcome, dig deep into these research studies. They're phenomenal. But just there's a significant link between brain injury and suicidal ideation. This bottom one's probably one of the more powerful ones, which is even controlling for age and gender. A person with a history of a TBI is 2 times as likely to die by suicide compared to those folks without. And this is referring to veterans in this case, but doubly as likely. And it's not just much of the data that we see around suicide is pertaining to suicidal ideation. This is talking specifically about death via suicide. So this is not like a minor issue. When I'm talking to veterans, I talk about this very much, that this is a life and death concern. Another group that's strongly impacted are folks experiencing homelessness. So you put this nexus, I mentioned veterans, I mentioned folks who are without a place to live. You put those two together, this particular sample, which was a systematic review and meta-analysis, 93% of vets sampled who had been homeless reported a history of brain injury, which is, in my mind, again, it's a staggering statistic. Part of the reason, though, that it's important to note this is that homelessness and brain injury likely share what's considered a bidirectional relationship. And the easy way to explain that is, if you are a person who has a history of brain injury, you're more likely to be experiencing homelessness at some point in your life. If you are a person who has experienced homelessness in your life, you're much more likely to have sustained a brain injury. And again, I use the word intuit a lot, but you might be able to figure out, okay, why that might be. But the obvious reasons are if you've had a brain injury, you're likely to sustain symptoms that can make it harder for you to function in your day-to-day life. If you're a person who doesn't have a place to live, and you're trying to stay up at night to make sure that you're safe, you're more likely to be assaulted. You're much more likely to be in spaces where you're not of sound mind and able to take care of your body, and you're at higher risk of falls. So it's a pretty clear bidirectional relationship between these two issues. The other one that I will 100% get into, as I said, is just mental health concerns. So mood disorders, suicidal ideation as a function of those things, anxiety, PTSD, and substance use disorders. I'll also, maybe this is a teaser, but I plan on talking about psychotic disorders as well, or psychosis and its relationship to brain injury, because that seems to be something that folks appreciate hearing a little bit more about. So I'll go into detail on that in the next presentation. One thing to note just about mood disorder, I'm going to come back to this slide again because it's a really important one. Most common mental health concern post TBI are mood disorders. Most of the time what it looks like is major depressive disorder, and in general, the other thing that's really challenging about it is that it has a comorbid presentation with anxiety about 75% of the time. So I kind of joke, like when I'm writing up my case notes or my progress notes or something, it's actually pretty odd for me to not write, when it comes to brain injury, symptoms of depression and anxiety. And so when someone just reports one, or let's say they take an assessment like the PHQ-9 and GAD-7, and we're assessing for anxiety and depression, I'll have to delete. If someone doesn't have symptoms of anxiety, I've got to delete that note real quick because I need to make sure that I've caught what's actually going on for them. And it happens so often that these two are just put together. So it's really easy for that to happen. Another note is what I mentioned earlier, which is mood disorders have a frequent development without pre-injury history. Sometimes, and this is an epidemiological study, but sometimes people make the assumption the only way you're going to get depressed after a brain injury is if you were depressed beforehand. And that's absolutely not the case. Brain injuries exacerbate depression. Brain injuries can also create depression. One of the most powerful presentations, I went to this I got to be in Maine last week, and it was awesome. I had never been before, and attended the State of the States conference thrown by the National Association of State Head Injury Administrators. And one of my favorite presentations was this presentation related to IPV and DV, because this quote to me is one of the more powerful. If you take nothing else from this presentation, remember how often domestic violence and IPV lead to brain injury. So I'll just read it for you. The numbers of women who have brain injury inflicted by a violent partner are estimated to be staggeringly high, higher even than NFL players or those who are injured in military service, just to give you a sense of the scope. All right. Another note about this, of the 255 brain injury screenings completed at DV shelters, 61% of women were considered to be positive for brain injury. I've seen that number higher. In this case, of 115 patients in another retrospective study, 92% of those who reported one or more brain injuries related to DV reported too many injuries to quantify. So the other thing to be thinking about, and when we're talking about brain injury in general, is that sometimes people can get caught up in thinking, I've had a brain injury, and therefore, I've got all these issues that I'm dealing with. What could another injury matter? I see that a lot with people who like to engage in these risky behaviors, or I mentioned riding motorcycles or ATVs, stuff like that. The hard part is that once you sustain one brain injury, you're much more likely to sustain more. When it comes to being involved in a relationship that has an intimate partner violence, that absolutely is exacerbated. So you will find people who will get to a point where they can't even remember how many injuries they've sustained over time. The other group I mentioned, by the way, I'll just pause here for one moment. This is definitely the doom and gloom part that I'm talking to you about. I apologize for that. I will get into accommodations, I promise, but it's just, there's really no way to talk about groups that are at high risk of brain injury without getting into some of these stats, and they're pretty devastating. So allow me to present some more. Approximately every other person involved in the justice system has a brain injury. This is the most conservative stat that I present related to brain injury and justice system. The reason I present it is because it's the lowest number that I feel comfortable with. When you look at colleagues that presented, for instance, recently in Pennsylvania, looked at colleagues who presented in Colorado, and you ask them, because these folks have done extensive studies within the Department of Corrections in each of those states, when you ask them what percentage of folks have brain injury, this is not the number that you'll get. In Colorado, the last number I saw was 72% of folks within their system. In Pennsylvania, that number was closer to 90%. And what to me, again, was powerful about that number out of our researchers out of Pennsylvania, it wasn't just 90%. It was also that they're studying two other symptoms of brain injury. They were looking at working memory and they were looking at executive function, because they didn't just want to know, are these folks who've just had a brain injury, but they're fine, they've had no issues? So they wanted to look at what symptoms are involved. That 90% are folks who have had a history of brain injury and have a reduction in their executive function and a reduction in their working memory. So these are staggering numbers within these communities. When I talk to folks who work in these settings, I talk more about brain injury or neurologic informed care, which is really similar to trauma informed care, which in my mind is making the assumption that because these numbers are so high, assume the people you're working with have a history of brain injury and try to provide some appropriate accommodations as well. All right, this is, I guess, another pause point. Are there any questions that I can answer during this pause point?
There was one question earlier for when evaluating someone with a brain injury, would a neuropsychological evaluation be a recommended assessment or to be referred to, or would there be another assessment for brain injury that would be more appropriate?
Awesome question. Awesome question. Yeah. So the way that I talk about this is, I mentioned doom and gloom. It can feel a little bit sad. So neuropsychological examination is considered the gold standard when it comes to brain injury. If you can get somebody a neuropsych, that's awesome. The last time I called Oregon Health Sciences University, OHSU, and said, hey, I have a patient who I want to get a neuropsych exam. What's the wait? It was about 1.5 years ago that I called, and they told me the wait was 19 months. So despite it being the gold standard, getting somebody a neuropsych exam can be really challenging. If you're somebody who does it, it's really, really, really important work, particularly for folks with brain injuries. If you have good resources within your community for that kind of thing, don't take it for granted. It's a wonderful, wonderful resource to use. And at the same time, because, for instance, in Oregon, with that difficulty at finding neuropsych exams, I really encourage people to learn accommodations, make assumptions that the people that you're working with are going to have some issues with brain injury, and then, use these accommodations in doing the type of work that you do best. If you do OT, if you're a therapist, if you are providing peer support, you should still know and be able to provide some form of accommodation so that every person with a brain injury doesn't require a neuropsychological exam, because frankly, in some cases, it's a privilege to have the opportunity. Okay, awesome. Yeah, I'll keep pausing and then definitely have room at the end, hopefully, for questions. I want to get into screening. So, that's really sad to hear that the wait times for neuropsych are similar in Maine. I'm not surprised, but it's also sad to hear. So why is screening important? So screening is important for a couple of reasons. A history of brain injury may not be known to medical providers. That should be a pretty obvious one. But unfortunately, what happens a lot of times, and I don't want to exaggerate the issue, but I've seen quite a few examples of people going into ERs. Let's say the example I always give is getting hit in the nose with a baseball. Someone gets hit in the nose with a baseball, they go to the ER, they go through this whole process. Hopefully at some point someone assesses for brain injury in some capacity, for concussion. But what ends up happening is they go through the whole process, and then when you look at their diagnosis, the thing that is left in their medical chart is just that they had a broken nose, and maybe there's not a mention of concussion. So it's really easy for a concussion or some mild traumatic brain injury to be left off of diagnoses and left off of medical charts. So it's not a guarantee that providers are going to have that information. If it's a mild traumatic brain injury, really often it's not going to show up in MRIs or CT scans. Just one note about taxonomy, I'm saying mild traumatic brain injury. You can have a loss of consciousness. You can have a brain injury that involved a loss of consciousness for 29 minutes, less than 30 minutes, and have it still be considered in certain taxonomies a mild traumatic brain injury. That sort of injury can absolutely, if you lost consciousness for 20 minutes, that can impact you for years and in some cases the rest of your life. And then when you're looking again at a medical record, all you're seeing is, oh, you had a mild traumatic brain injury when you were 22 as a result of a car accident. Like, people who don't understand mild and loss of consciousness for 20 minutes are, in my mind, really, really different things. Let's see, untreated brain injury would definitely have no medical documentation. So folks didn't even go in. In football, this is a big thing. Having your bell rung is the term that I grew up with. So you had your bell rung at practice, you got some rest, maybe you felt a little dizzy for a day or two, and then you kind of went on about your business. That type of thing, there's not going to be any medical documentation. And then, yeah, I talked about the effects of brain injury impacting treatment and services a client is receiving as well. This is one of my favorite slides, and I can't take any credit for it, because anytime you see a slide that's like pretty and has colors, it means that I wrote something that was black and white and somebody who's smarter and better at creating slides did something like this with it. But what I love about it is it talks about steps. So the first step is actually a screen for brain injury. When I tell people to screen, there are a lot of different ways that you can do it. So the one that was referenced earlier, which is the OBIS, is phenomenal. It is an opportunity to get it's an online screening using what's called the OSU TBIID screener. And you take the screener, you get a symptom inventory, and then you even get like recommendations and potential accommodations. So that form of screening is awesome. When I'm talking about screening, though, for the purposes of something like this, and if you're going back to your organization and you just want to think about screening, I'm always just talking about just ask the question, like ask if the person's had a history of brain injury. If you want to go above and beyond and like do the best evidence-based practice associated with this and use the OBIS or use the OSU TBID, great. If you can even ask a couple of questions, you can say things like, have you had a history of brain injury? Have you ever been in a car accident? Have you had a history of seizures? Like, even have you had a drug or alcohol overdose? Including just those 2, 3, 4 questions, to me, is a phenomenal example of a screen for brain injury. You don't have to go all the way to the absolute best practice, even though I'll recommend it if you have an opportunity, which apparently you do in Maine. So screen for brain injury, recognize what's the functional impairment, what's going on, how's it impacting them, provide accommodations, which I'm going to be talking about in a minute, and then integrate with community resources, which again, the fact that your BIA is throwing an event like this and having an education like this means that there are really good community resources. There are people who know about community resources. Those are the people that you need to get to know once you're doing this work. And then monitoring and managing co-occurring health and mental health issues as well is really important. All right, so I've been referencing the accommodations piece for quite some time. I want to make sure that I hit this. There's two, I've really become a bit of a snob when it comes to accommodations because there's a couple of points I think they get left off quite a bit. So an accommodation is a modification or adjustment made to the way things are customarily done to enable better access. That's what it's for. Sometimes, again, people get caught up and they think that if I'm going to help somebody with brain injury, I have to reshape everything that I do. So when I got called in to work with the Department of Corrections at Snake River, they said, come to our location, tell us about the lights and the placement and everything that we can do structurally to make this a better spot for a brain injury, which I think is awesome if you have the opportunity. But an accommodation doesn't have to be changing every light bulb in your facility to make sure that it's not these bright fluorescent lights. It doesn't have to be making sure there's no ambient noise whatsoever. You've got all of your doors blocked so that nobody can hear any ambient noise. It's just, there are even shifts within language, shifts within the way that you interact with a person that is still considered an accommodation. So I get up on my high horse on that one. The other one I'm up on my high horse on is this one, which is like, and I'm hoping that I'll give you some examples from this presentation that you can take back as potential accommodations. But just if you can imagine for a minute what it might be like if you're working with somebody with a brain injury and someone says, I know that you have a brain injury. Tell me how I can help. What can I do for you? And leaves this very broad question out there. What happens is often people feel overwhelmed. They say, what do you mean, how can you help? Like, are you going to help me get to every single appointment and give me like set timers? Are you going to, make sure that I understand every single piece of paperwork? Like what are the things that you can do to help me? And so what I encourage folks, if you want to be brain injury informed, if you want to be trauma informed in this way, is just think a little bit about it beforehand. Think about, where do I work? What kind of space am I in? How can I make this space a little bit more accommodating to a person with a brain injury? And then rather than ask, how can I help you? Say things like, would it be helpful for me to draw the shades while we talk so that there's less light in this room? Would it be helpful for me to shut the door so I can make sure there's less sound coming in? Like having a couple of ideas of accommodations that you provide for a person with a brain injury is a wonderful way to start. And so, yeah, there's a lot of examples. And I know too that if you have access to OBIS, there are quite a few accommodations that you can get from that work as well. Just having examples of your go-to accommodations can make a world of difference. Great. Yeah, this link is exactly what I was referring to. So there's a flyer about OBIS here, but there are quite a few examples of accommodations you can receive there as well. All right, so here are some examples of the accommodations that maybe people don't consider all the time when it comes to brain injury. So simplifying and repeat your messages. I speak in a lot of places where I'm expected to use, really, academic vernacular, right? I need to use language that makes the University of Oregon look good and all this kind of stuff. When you're doing accommodations for a person with brain injury, if you can't explain what each and every word that you're using means, I would just argue don't use it because you want to use language that's familiar to this person. And if you're presenting folks with language that's really challenging, you're basically setting yourself up to have the rest of the sentence that you're uttering not be understood. So you want to try to use the most familiar language that you can. Trying to keep recommendations simple. Using simple calendars and reminders that can be carried is a huge piece. One of my, when I talk about interventions for folks with brain injury, I think people always think I'm doing some kind of cognitive rehabilitation and working on the frontal lobe and all this kind of stuff. And it's one of my favorite interventions for a person with a brain injury is sit down with them and say, okay, we're going to be meeting every week. Here's a way that you can set your calendar up so that you can get a reminder every single week, an hour before we meet, so that you know that you're not going to be missing our meetings. Literally just sitting down and doing that is a wonderful accommodation for a person with a brain injury. I've been referring a lot to reducing distractions. I have a ton of stories. Most of this actually has been anecdotes, but I have a ton of anecdotes about examples of spaces where I work in a place, I notice that there's ambient noise and that I'm having a hard time with somebody, and all of a sudden being able to move to a different room makes a world of difference. I worked at the sheriff's department down in South Orange County, California, and I was working in the interrogation room, was where they had me doing therapy sessions for older adolescents. And for some reason in the interrogation room, nobody was being able to remember their meetings. They were having a really hard time remembering the things that we're talking about. And so at one point I just asked, I was like, can we get out of this room that has this beam of light shining on one person and get into this was almost like a little closet area that had more space and a couple of chairs, but way fewer distractions. And all of a sudden, what do you know? People were able to pay attention a little bit better. So being able to reduce distractions, check in regularly. Are you understanding the information? Checking for comprehension is a huge piece. The other thing that I love to do is prioritize and plan. So I'll do written notes for folks with brain injuries. So I'll talk about a thing. I'll check in, make sure that there's comprehension. I'll make sure that they've repeated back the thing the way that I said it the first time to make sure that we're on the same page. I'll write it down. And then I'll even within the writing, I'll like say, okay, these two pieces are the most important, and we'll underline, highlight, do whatever we can to prioritize, because being able to go through a document requires quite a bit of cognitive load, and being able to reduce that even by just prioritizing a couple of specific points can make a huge difference. The other thing I always encourage people to do, speaking of cognitive load, is just building routines. So if you know that you're going to be working with somebody with brain injury regularly, you're going to see them like, you're going to see them at least once a month. Try to have that day hold some consistency. So if it's the first Thursday of every month, awesome. Because what that's going to do is it reduces the cognitive load required to be able to remember the appointment, remember what you're going to be doing, and then all of a sudden it becomes a part of the routine. Oh yeah, it's Thursday. It's the first Thursday in November. I'm going to see Doug, and it kind of like it makes it a little bit easier for a person to engage in that appointment because they have some consistency and it's somewhat predictable. The last little bit that I really always highlight is one of my favorite quotes from one of the previous directors of our grant, who includes this in all of her slides, so I'm going to do the same. When a person's behavior differs from their stated goals and intentions, assume they're doing their best and determine what supports will allow them to be more successful. When I talk about accommodations, like none of these things should be mind-blowing. Like nothing that I just said should be like, oh my gosh, I can't believe that. I would have never thought to like write down things for the people that I'm working with. The thing is, if you're not assuming that the person's doing their best, it's really easy to assume that someone is deliberately not paying attention, not taking your advice, not engaging in your program, and even like taking that personally. So coming at it from a space of making the assumption folks are doing their best and that your job is to figure out how can I support you in that? How can I allow you to be more successful in your work? For me, that was a total mind shift, and all it involved was a little bit of empathy. The last little bit, I'll skip this cloud for now, is just kind of my conclusion, which is brain injury symptoms. Hopefully I've convinced you at least up to this point, these symptoms impact functioning in all aspects of life. It's really important to acknowledge and integrate that it's challenging to overcome life circumstances, and it's all about perspective when it comes to accommodation. That last bit, like you will be so much more creative as a person if you view, hey, look, like this person's really struggling. It's my job to try and provide a way to accommodate for them. You'll like some of the most creative responses I've ever had have involved me needing to be to show empathy for the person across from me first, because having somebody show up like late to every single appointment, especially when your appointments are really important and maybe you're somebody who really values your time, that can be challenging. It's easy to take personally. So I try to just say like your perspective matters with your ability to accommodate and your level of empathy you're able to provide for the other person. Okay, let's see here. So last steps is just what can you do if you think someone has experienced a brain injury? Learn simple screenings, learn what accommodations you have so that you can provide them, and then help get people connected to resources. There is some significant resource navigation through BIAA Maine. I'm happy to help people navigate to resources if they need it, but I kind of just want to put that out there to folks. So that's mostly what I have today. I want to include these slides just in case you're a research person. These are some slides we did related to a needs assessment in the state of Oregon. And then brain injury resource navigators can do some really specific work that's important as well.
Thank you, Dr. Gomez. We have a couple questions.
Absolutely.
I think we've got 5 minutes left. So the first one says, do you have experience working with people with cerebral amyloid angioplasty and the impact this has on the brain? I'm curious how this can be distinguished from dementia when the symptoms are very similar.
So I personally do not. However, I'm going to include, I do talk about, if we're talking about similar symptoms to dementia, I do talk a little bit about that in my next presentation. And unfortunately, dementia and brain injury are pretty strongly linked too, because they're not the same thing, but also they can look really similar. And diagnostically, that can be really challenging too for a person with a brain injury because they're more likely to have symptoms of dementia earlier as well. So yeah, I don't have that experience myself though.
And then we have another question that says, as an LADC, I have an increase in clients reporting history of TBI. Do you think this is related to increased awareness and education or increased diagnosing of these injuries?
I really hope both. I really hope the answer to that
Me too.
question is both, right? I know that's the way that it is in Oregon. We're talking about it a lot more, so I'm hearing about it more from providers. But yeah, also I know that screening protocols have increased too, and I don't know. The more that people go to stuff like this, the more that people throw events like this where I get to talk about brain injury, the more likely we're going to see it, which is kind of what we want because the thing we don't want to see is what the veterans used to think or what the VA DoD used to think, which was that, oh, we just don't have that many brain injuries. And then all of a sudden, one year in 2001, we saw the number of brain injuries go up drastically. And they're like, what happened? Is it the way that combat happens now? It's like, no, it's because people are aware of it and they're asking the right questions. They're doing screenings. So yeah, I feel pretty strongly about that one, obviously. But yeah, I hope the answer's both.
Are there any other questions? We've got a couple minutes if anybody has any and wants to pop them in the Q&A. Just like I said, tidbits in Maine, we do have access to the OBIS. It is free. So please reach out to me if you are interested in using it within your organization or even just with a particular client. Part of our grant work is to bring you great speakers like Dr. Gomez, but also to facilitate identification of brain injury in underserved populations here in Maine and provide education and support to providers working with those individuals within the systems that they're already getting supports and just adding that neuro-informed piece that Dr. Gomez spoke about. So I will pop my information in the chat again if anyone needs it. And thank you so much, Dr. Gomez. We can't wait for next week.
All right. Thanks for having me.
Thank you very much, Dr. Gomez, for your presentation today, and thank you to Adept Institute of Maine for hosting the webinar. Thank everyone who is in attendance today for joining us, and I hope you have a great day, and we hope that you can also be in attendance next week. Thank you.